السلام عليكم طلبتي الأعزاء. Today we will discuss symptoms of heart disease, and we will discuss the causes of these symptoms and the most important questions to be asked for each of these symptoms. These symptoms will include chest pain, dyspnea, palpitations, syncope, fatigue, peripheral edema. Particularly the chest pain, we will apply the questions that we trained ourselves to ask about the symptom analysis of each symptom. Chest pain, one of the commonest symptoms that present in the medical field and the clinical practice. And one of the important things that we talk about in the previous lecture is about the severity assessment, about the how we can have a scale for the assessment of the severity and risk stratification. And the best example is the New York Heart Association NYHA functional classification. This functional classification will classify the patients into four classes depending on the level of exertion that exert or precipitate shortness of breath. In class 1, there is no limitation during ordinary activity. In class 2, there is a slight limitation during ordinary activity. Class 3, marked limitation of normal activities but without symptoms at rest. And class 4 means that the patients are unable to undertake physical activity without symptoms, and symptoms may present even at rest. One of the important duties for you as currently as a student, and in near future you will be a junior house officer, is to differentiate between ischemic pain and non-ischemic pain, because your main duty in the emergency department, for example, is to save the life of the patient even before achieving the diagnosis. So the urgency of the procedures and maneuvers you do and the action plans for the treatment of the patient, its main objective is to save the life of the patient and, of course, the diagnosis at the same time. So, chest pain per se, we have to differentiate between life-threatening causes of chest pain first, and second, we should also differentiate between ischemic pain and other non-ischemic pain, because ischemic pain needs special maneuvers, special treatment plan, a special monitoring, for example, and and in need for urgent action, while other causes for chest pain might be less urgent in its priority. The life-threatening chest pain, just to remind you, can be caused by one or four causes. The four causes of life-threatening chest pain include acute myocardial infarction. Second is massive pulmonary embolism. Third is tension pneumothorax, I'm sorry. And at the last is the aortic dissection. The differentiating points between different types of chest pain depends on these 6 points. First thing, the site. The site is very important because ischemic pain is retrosternal or central in site. Another important feature of ischemic chest pain is that it is ill-localized, meaning not well-localized. It's diffuse chest pain because of the poor nerve supply of the heart. The radiation is characteristic feature for ischemic pain that is not present in almost all of other causes which cause non-ischemic chest pain. The site also important to differentiate into two kinds of chest pain, the central chest pain and the lateral or peripheral chest pain. Peripheral chest pain, always pleuritic, musculoskeletal in nature, and it is not ischemic, while the central is ischemic, is more going with ischemia, but we have other causes like esophagitis, mediastinitis, and aortic dissection that might cause central chest pain with non-ischemic in nature. The character also is an important feature that differentiate between different kinds of chest pain. For example, constricting heaviness or tightness is characteristic of chest pain, although not uncommonly, atypical chest pain may come and sometimes even is stabbing. But the localized and persistent pain, for example, is more going with the musculoskeletal, and we have the burning chest pain that is associated with esophagitis. The propagation is important because chest pain of ischemic nature is more or is always should be exacerbated or precipitated by exertion, physical or emotional exertion. While in cases of esophagitis, for example, or esophageal spasm, taking a meal might be the precipitating factor. While at night it occurs more the musculoskeletal pain. The onset is important. The acute onset is going with acute myocardial infarction. More insidious onset might go with musculoskeletal sometimes. The associated features are very important points, differentiating points between different kinds of pain. For example, if I have chest pain that is central, radiated to the neck, and there is also associated with the nausea, vomiting, excessive sweating, feeling of impending death. This is more going with acute myocardial infarction. When a, when a chest pain come with cough, associated with cough, is more going with, for example, tracheitis or bronchitis. So associated features might we might have a significant positive and significant negative symptoms or features that might exclude or confirm the suspicion or the diagnosis and achievement of the professional diagnosis. So, pain is standard questioning for every patient with pain, wherever the pain was. We should ask about the site, the onset, the character, the radiation, the associated symptoms, the timing, including the duration, the course, the pattern, the duration of the illness, the duration of the chest pain, and when it comes an attack, it is not persistent, and the course, is it progressive, rapidly progressive, or the course is that there is some relief, the pattern, is it persistent or not persistent. The exacerbating and relieving factors are important, and the severity should be assessed in an objective way rather than depending on subjective feelings. Now, one of the important differentiating point, as we talked just a few minutes ago, is about the differentiating of chest pain into two main types, the central and the peripheral chest pain. The central chest pain, the big question is about being cardiac or non-cardiac in origin. While the peripheral, the main question is about being pulmonary or non-pulmonary in origin. So, central chest pain, the cardiac causes include the commonest one is ischemic heart disease, including infarction or angina. It might be caused by pericarditis and myocarditis. Mitral valve prolapse is an important and common cause for central cardiac chest pain. Aortic aneurysm and dissection also, and we mention it as one of the important life-threatening causes of chest pain. Non-cardiac but central chest pain might occur in pulmonary embolism, esophageal disease, mediastinitis, costochondritis, like Tietz's disease. Costochondritis means that inflammation of the cartilage connecting the ribs with the sternum. So this is called as Tietz's disease. Trauma to the center of the chest, whether trauma affecting the soft tissue of the chest or even might involve the rib itself. Peripheral chest pain, as we told you, it is either pulmonary or non-pulmonary. Pulmonary, it might be pulmonary infarction, pneumonia, pneumothorax, lung cancer, mesothelioma, and non-pulmonary, including herpes zoster, whether and trauma, whether ribs to the ribs or to the muscles. This picture shows how the patient with ischemic chest pain failed to localize the pain by pointing by one or two fingers. So he clenches his fist or use his hands to simulate how diffuse and ill-localized the chest pain he has. In this picture, in the lower quarter, you see the site of radiation. Here, the main site of pain, then radiated to the retrosternal state, to lower jaw and to the neck and to the inner side of the arm. And here, one of the important features, it is pain in the arm, rather than paresthesia or anything else. Here, the site and radiation of ischemic chest pain also. Now we come to specific features of chest pain in different types of or different causes. In angina, it is the chest pain is retrosternal, dull ache or discomfort. So it might be not a pain, it is discomfort, عدم ارتياح. It is ill-localized, cannot be localized by one or two fingers. Crushing, heaviness, like a tight band. This is the character of the pain. Worse with physical or emotional exertion, cold weather, and after eating. And this is the precipitating factors. It is relieved by rest and nitrates. Nitrates is a vasodilator for the coronary artery. It is not affected by respiration or movement because it is a visceral pain that originated from the heart, not from the peripheral tissues. And so it is not affected by taking a deeper breath or movement of the chest, sometimes associated with shortness of breath. In myocardial infarction, we have similar pain because both of them caused by ischemia. And this similar to that of angina, but it is first more severe. The patient will have very severe pain that prevent him from doing anything. More persistent, the duration of the chest pain in angina, almost always not more than 5 minutes. It is usually 2 to 3 minutes. While in cases of acute myocardial infarction, might be more than 20 minutes or even 30 minutes. It is associated with nausea, vomiting, and sweating. This is a parasympathetic features due to the stimulation of the parasympathetic system. Associated feeling of impending death because of the severity of the chest pain and the effect of that myocardial infarction on the function of the heart, the feeling of impending death, that death is inevitable, is sensed by the patient, is felt by the patient. In cases of pericarditis, because that here the problem is not in the myocardium, there is no infarction, it is mostly inflammation of the pericardium. It is constant retrosternal, constant meaning persistent. It is not related to exertion. It is worse on inspiration because it is a pleuritic in nature, and there is also some pleurisy or inflammation of the pleura that is adjacent to the pericardium. So, on taking deep breath, say there will be a friction over the inflamed area and some increase in the severity of pain and pericarditis during inspiration. Relieved slightly by sitting forward because this will make gap between different layers of the pericardium. It is not related to physical or emotional exertion. Now we come to an important cause for life-threatening chest pain, which is aortic dissection. Here the site is also central and often felt first between shoulder blades and or behind the sternum. The onset is usually sudden. The nature is very severe pain, often described as tearing. Tearing, when you once you read it or you hear it, suspect aortic dissection, because the treatment of aortic dissection is greatly different from that of myocardial infarction, particularly from the indication for thrombolysis or the use of anticoagulation. So the differentiation between aortic dissection and acute myocardial infarction is very important to save the life of the patient and act urgently to treat in the proper way. It cannot be relieved by anything, so there is nothing to relieve it. It tends to persist, and patients often restless with pain. It is accompanied by pallor, sweating, hypertension, asymmetric pulses, unexpected bradycardia, early diastolic murmur, syncope, focal neurological symptoms and signs. Of course, pallor, sweating, hypertension, because hypertension is a risk factor for aortic dissection. Asymmetric pulses because of the origin of the clavicular subclavian artery is different from the left and the right. Unexpected bradycardia because it might involve the supply for the SA node, and early diastolic murmur because it might go down up to the aortic valve and cause aortic regurgitation. Syncope, focal neurological symptoms and signs because of the failure to supply the brain with adequate blood supply. Esophageal spasm, it's often mistaken for MI or angina. It is a severe retrosternal burning chest pain. So burning chest pain is more going with esophageal diseases. Onset often after eating or drinking. It may be associated with dysphagia, may have a history of dyspepsia, may be relieved by GTN, needs more time than that required for angina, about 20 minutes versus 2 to 3 minutes in angina. In esophagitis, the chest pain is characteristically retrosternal, burning pain, heartburn, felt like heartburn, relieved by antacids, and the onset usually after eating. A pleuritic, which is usually respiratory pain, it is sharp pain that is worse on inspiration and coughing. It is not central, as we told you before. It is occur in the peripheral sides of the chest. It may be localized to one side of the chest or one area of the chest, depending on the cause and the size of inflammation or infarction or the lesion. No relief with GTN, there is no radiation. It is associated with breathlessness, cyanosis, cough, meaning respiratory symptoms or signs. Musculoskeletal pain, It is localized to particular spot on the chest, worsened by movement and respiration, and it is tender to palpation. Here we summarize the lecture, and our main duty is to differentiate between ischemic cardiac chest pain and non-cardiac chest pain. And regarding the location or the site, the ischemic chest pain is central and diffuse, while the non-cardiac chest pain is peripheral and localized, well localized. The radiation in the ischemic pain, the jaw, the neck, the shoulder, the arm, occasionally the back, while in non-cardiac pain, it is other radiation or no radiation, almost always no radiation. The character tight, squeezing, choking, while in chest pain due to ischemia, and it is sharp, stabbing, and catching in cases of non-cardiac chest pain. The precipitation, ischemia is precipitated by exertion, physically and or emotional. The precipitation can be spontaneous, not related to exertion, provoked by posture and respiration or palpation. This is for the non-cardiac chest pain as a precipitating factors. Relieving factors include rest, quick response to nitrates, and ischemia, while in non-ischemic pain, there is no relief by rest, a slow or no response to nitrates, particularly for the esophageal spasm, there is a slow response, and no response when there is musculoskeletal chest pain. Associated features breathlessness and ischemia, while in non cardiac pain, respiratory, gastrointestinal, locomotor, or psychological features might present, suggesting non cardiac chest pain. I think that I will go also rapidly to discuss the breathlessness or shortness of breath and dyspnea. Breathlessness dyspnea is an awareness of increased drive to breathe and is normal on exercise. This is the definition of breathlessness or shortness of breath. So when I become aware of an increased drive to breathe, this is called breathlessness, dyspnea, or shortness of breath. Usually, it is normal in exercise. It is pathological if it occurs at a significantly lower threshold than expected. And breathlessness is a non-specific symptom and may be caused by many systems like cardiac, respiratory, neuromuscular, and metabolic conditions, or by toxins or anxiety even. One of the important features of dyspnea that occur in heart disease is that orthopnea or dyspnea on lying flat and is a sign of advanced heart failure. It is caused by the mechanism of that lying flat increases venous return to the heart, and in patient with a failing left ventricle may precipitate pulmonary venous congestion and pulmonary edema because the heart cannot comply with the excess venous return. And you know that cardiac output should be the same as venous return. The severity can be graded by number of pillows the patient uses before feeling comfortable, 3 pillows or orthopnea. Regarding paroxysmal nocturnal dyspnea, it is also a kind of orthopnea, but it is sudden breathlessness which wakes the patient from sleep, choking or gasping for air. It has a similar mechanism to orthopnea and is caused by the gradual accumulation of alveolar fluid during sleep. The increased venous return will be increased gradually, building up excessive pressure and excess volume load over the heart until the heart will fail and there is pulmonary venous congestion occurring, leading to alveolar fluid excess and edema. Patients may sit on the edge of the bed and open windows in an attempt to relieve their stress. So dyspnea can be caused by left ventricular failure in cases of pulmonary congestion or pulmonary edema. Pulmonary embolism can be an important cause for dyspnea. Any respiratory disease might cause dyspnea, and anxiety is an important cause for dyspnea as well. I think I will stop here for today, and I will continue the discussion of the symptoms of the heart diseases in the next lecture tomorrow afternoon, inshallah. Thanks for your kind listening and waiting for your comments and question, dearest student.